Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. Today's episode features Dr. Alexander Wong with the University of Saskatchewan as he discusses his clinical experience on providing and maintaining retention in HIV care for persons with substance use disorders. This episode is part of a larger educational program titled You're Welcome, ensuring HIV services are inclusive and equitable. For more information on Dr. Wong, along with the link to the full educational program, please visit the link in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started and hear what he has to say about this topic.
So, a lot of the principles that our clinic has and pushes forward with regards to trying to optimize kind of engagement and retention in care are probably not like a surprise or unique to a lot of more experienced HIV care providers. So we exist in southern Saskatchewan, which is a Canadian prairie province. For those of you in the United States, we're above Montana and North Dakota, just for reference. So we're like in the middle of Canada. So there's like a lot of farmland and stuff like that. So we have a unique dynamic here in our province specifically. We have the highest incidence rates of HIV in the country, several times higher than that of the Canadian incidence rate. And a lot of that is driven by, social, cultural, and economic disparities that are historic and disproportionately affect large proportions of individuals with Indigenous heritage and background, as well as, a large proportion of younger individuals, a large proportion of people who are of female gender. And historically, the majority of our transmission was related to the use of injection drugs. That has recently changed over the last several years as individuals have kind of changed the way that they have used their substances. And it's moved from injecting substances like cocaine and crack, for example, as well as prescription opioids, to the current dynamic now where the predominant stimulant is crystal methamphetamine. Most of that is inhaled, although some of it is injected. And then obviously the synthetic opioids, including fentanyl and all of the various analogs of fentanyl, which again is mostly inhaled, although some of it is definitely injected as well. And so historically, what that's led to for us, when I started here in 2010, 2011, we saw a very, very high proportion of newly diagnosed individuals with co-infection with both HIV and viral hepatitis C. Hepatitis C is obviously just a marker for parenteral sort of transmission of bloodborne infection, reflecting some of the risk dynamics, and that has now changed dramatically. We have a massive syphilis epidemic that exists across the Canadian prairie provinces and is spreading, both to Western and Eastern Canada. And so the proportions of HIV and syphilis co-infection now that we see are also dramatic, and again reflect some of the current transmission dynamics as well. So amidst all of this, there is a very high proportion of persons who use different types of substances. And in our setting, there's definitely some alcohol use disorder, but the majority of it is going to be persons with either opioid use disorder or stimulant use disorder or both. And oftentimes it's both. People will typically have a preferred substance of choice. And what we found predominantly is that given the potency of synthetic opioid analogs and fentanyl analogs specifically, any degree of fentanyl use usually ends up having it be sort of the primary overriding sort of use disorder that when people come in, that's kind of the piece that kind of largely has to be addressed up front as kind of like one of the main medical priorities. So none of this, again, is probably news to everyone, but we struggled in our community just being able to access timely sort of on-demand sort of addictions-related sort of services and care, whether that's kind of the non-medical components, including counseling and other social supports, as well as the more medical pieces, including, provision of opioid agonist therapy for persons with opioid use disorder, as well as, provision of, other sorts of treatment options and settings, including inpatient and outpatient sort of programming and residential type settings for people, with both opioid use disorder and stimulant use disorder. So several years ago, again, I'm an ID physician. I was trained as an ID physician, but we basically took on a desire to be able to provide co-located sort of OAT addictions related services on site because we saw that it was such a massive need and because we saw such a high proportion of people coming in with opioid use disorder and we couldn't necessarily help them, right? And so in the end, prescribing antiretroviral therapy, and I don't mean to sound crass, but HIV care in 2024 is not really all that hard in the sense from a medical perspective. The pills are so good at this point and almost infallible and quite forgiving. So really being able to get people to be able to take a pill once a day, they don't even have to be perfect with that pill, but the barriers to having people be able to take pills in a way that is going to be regular and predictable and optimal is more complicated, and addressing those barriers for each individual is an individualized exercise. So we take on a very individualized approach with all newly diagnosed individuals and individuals who are, lost to follow-up that we're trying to re-retain in care. And the main things we focus on right up front are usually the immediate basic needs around housing, food, relationship, income insecurities, which are usually present, as well as whether or not there's coexisting substance use disorders or mental health related disorders. And those pieces are usually going to be the priority pieces that we find need to be addressed in a very timely and appropriate manner up front. And if they're not addressed in a way that's successful or sustainable, then retaining someone in HIV specific care, i.e. getting someone to be able to take like a pill a day or be able to come in for their injection every 1 or 2 months, for example, that's not going to work. So that's really our entire clinical practice. And, so we have a lot of individuals co-located in our clinic that have special expertise with regards to being able to address and provide those pieces that are really needed, including outreach workers, social work. They're obviously critically important with regards to managing all of the insecurity related issues, income, food, housing, and so forth. We obviously can't just snap our fingers and get someone immediately housed, but coming up with realistic plans to be able to safely be able to put someone into a setting where they and their family or their kids, are going to be able to be safe and warm and not worry about personal danger, for example. Those are all going to be the most important pieces that are going to need to be addressed. And when you do those things for clients, that again helps to build that immediate sort of trust and understanding that this isn't just about taking a pill. It's not the HIV care necessarily, it's the priority, but it's about addressing all these other pieces that are going to be the priority that, we need to address. Opioid use disorder and substance use disorder are complicated, and again, we've tried to refine our practice and continue to refine our practice over years of clinical experience. I have an excellent ID HIV addictions pharmacist. She's a unique individual, but she and I provide sort of the bulk of the addictions and OAT related care. And again, I've learned a huge amount and refined my approach over several years to be able to get to a point where we essentially just try to have as low barrier an approach as possible in terms of encouraging our clients to be open and upfront with us about what they're using, what their goals are, and what they perceive their potential barriers to be, what previous experiences have looked like for them in terms of either trying to either access OAT or OUD care, either successfully or not successfully, and how is that colored sort of where they are today. And then obviously having a very intimate understanding, at least at a high level, of, the cultural, intergenerational, historical trauma dynamics that many, many people walk in with, and trying to be very, very respectful of that so that people feel as safe as they can be in an environment which is still very triggering and stigmatizing, such as healthcare for many of the people that come in the door. So, we can't necessarily fix some of those dynamics, but we try to at least acknowledge them in a very explicit way, and then try to essentially just ask people, okay, what are your goals? How can we support you? How can we kind of meet you in terms of where you're at? So this is just my personal bias, but there are ways to do OAT better. And again, when I did my training back probably 6, 7 years ago at this point with regards to OAT, we still had, methadone, buprenorphine, and slow release oral morphine. These are sort of like our most traditional kind of OAT options. And they're all tools, but just like with it, tools can be utilized either more effectively or less effectively to be able to optimize retention and engagement in care. And what we found is that adapting some of our clinical approaches with regards to OAT provision, based on, so I'm familiar more so with Canadian guidelines as opposed to American guidelines, but looking at some Canadian guidelines from Ontario, British Columbia, looking at the provision of OAT for persons who are, using synthetic analogs and fentanyl, their opioid tolerances are very, very high. So, using higher starting doses of full agonist opioid like methadone or slow release oral morphine, combining methadone and slow release oral morphine, and then up titrating more quickly, we found that that's been able to optimize and enhance both engagement as well as retention in care for a lot of our clients living with HIV with concurrent substance use disorder. We've also had a lot of success, over the last year or two with more heavy utilization of different forms of buprenorphine with regards to OAT. And I would personally say anecdotally that our best successes have been, when we've had a more flexible and individualized approach and, and people have been able to make, progress with regards to recovery with regards to their substance use disorder. OAT provision is hard, and helping and supporting people with substance use disorder is hard. And the nature of, persons with substance use disorder is going to be sort of like an up and down sort of thing. People will come into care, many will fall off, many will come back on again. This was a completely unique dynamic for me. When I started addictions practice, I was used to kind of, I don't know, like kind of batting close to 1,000 in sort of like the HIV and viral hepatitis side of things. And then all of a sudden to have people come and disappear, that was definitely hard up front. But you recognize that this is just the nature of how it is, and you have to kind of be okay with that. And we as a team need to be very open-minded and flexible with regards to people wanting to re-engage in care. There's basically no barriers, or you don't get a certain number of strikes and then you're out and then you can't come back to clinic and so on and so forth. It's a lifelong thing. And we try and be very flexible, again, as people sort of fall off and then are retained back in care. So this holistic approach where you're addressing mental health related pieces, substance use pieces, as well as all the life pieces is, to me, sort of the critical kind of secret sauce that's needed in order to optimize retention and engagement in care. It's incredibly labor intensive. It's not easy work, but when it's successful, it's incredibly rewarding. And it's kind of why we keep kind of doing what it is that we're doing. I think the last piece that I feel is worthwhile mentioning, just because I think we felt it all strongly, is that this is really hard work. And, at times it's unfortunate, but very common that people living with substance use disorders are just going to have some bad clinical outcomes. During the pandemic, in our setting at least, we had about nearly 15% of our cohort actually die. And the majority of those individuals, 3/4 of those individuals, unfortunately died directly as a result of substance use disorder, either overdose or complications directly related to the use of substances, like, for example, MRSA bacteremia and septic shock, following the use of substances. And the repetitive trauma, not only for the clients, but also for the team, like to literally have people dying, on every few day basis. Some clients that we had known for years and we had built such close relationships with, and all of a sudden they're just gone in an instant, was incredibly difficult and challenging. And without the support, I think, of the entire interdisciplinary team to help kind of just share that pain and share that sorrow and be able to spread that around. I mean, if I was just one individual trying to absorb all that, I'm not sure that I would have been able to get through. And so I guess I only mention this to say that this population and serving this population has been incredibly rewarding, but at times can also be difficult. And I've relied strongly and completely on the support of the people that I work with on a day-to-day basis to be able to help kind of get through. And so we're able to share, all of the happy moments and the successes that we've had with many of our clients, have had great outcomes and who we've been able to kind of support from hitting kind of rock bottom to being, so stable and so healthy and so productive once again. And we're just so happy to see that. And at the same time, when tragedy strikes, being able to share that, I think as a team, like it's important for all of us to be able to look after our team members, look after each other, because it's not easy work, but it's very rewarding work and it's necessary work to do.
Thank you very much to Dr. Wong, and thank you to our listeners for joining in. As a reminder to view the full program, you're welcome. Ensuring HIV services are inclusive and equitable, please click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.